On behalf of my colleagues at Karolinska Institute, in Makerere University, Ifakara Health Institute and EvaPlan, it's a pleasure to give you a whirlwind tour of the EQUIP project together with Joanna Schellenberg from the London School, who's here with us today. So, very quickly, what did we do? Based in Tanzania and in Uganda, EQUIP aimed to increase demand for and improve the supply of quality health services for mothers and newborns. And we implemented a quality improvement project facilitating the institution of QI teams at community level, at facility level and at district level in each of the districts we worked in Tanzania and Uganda. And importantly, those teams were built on existing structures wherever it was possible to do so. And the teams were trained and then mentored to apply it to attend improvement collaboratives so that they thought about what they were trying to accomplish, thought about how they'll know whether a change had been achieved, and then decided on what were the indicators of change that they needed to track. So they were trained in the use of plan, do, and study act cycles, which are key to improvement collaborative thinking for quality improvement. We applied a plausibility study design with one intervention and one comparison district in each country, using a continuous household and health facility survey in both intervention and comparison districts to track progress as the intervention proceeded. So, what did we find? First, an overarching learning from this project was that quality improvement was feasible to implement at community and facility and at district level, but it really took time to set up. And that meant that in the context of an intervention trial, we had less time for implementation than we would have liked. One of our QI team members said, "EQUIP's ended just when we're starting to like it." But using the continuous survey, we were able to track the point prevalence of our coverage indicators as the intervention proceeded over a period of 2.5 years. So we had 6 points, each estimated at 4 monthly intervals. Just illustrated there in the graph where you've got red dots indicating an intervention district point prevalence for a given indicator, and the blue dots indicating the point prevalence in the comparison area. And this example indicator that I'm showing you here is the percentage of women who are estimated to have received a prophylactic uterotonic at the time of birth. So we didn't have enough time at full implementation levels, but we did have some interesting results, although the results were mixed. So here in the table on the left-hand side, you've got a list of the topics, the implementation strategies that the QI teams had chosen to work on in both countries. There was a very mixed bag of things that the QI teams chose to work on. This was not a very directed QI intervention. It was very much left in the hands of people to decide for themselves what change strategies they wanted to implement. So overall, what we saw was a really promising picture of an increase in facility delivery, an increase in preparation of clean birth kits. So strong demand-side community behavioural factors being driven by community-level QI teams. And also a strong increase in both countries in the percentage of health workers who were delivering prophylactic uterotonics during births that they attended, indicating that health workers were able to decide for themselves on the behaviours that they wanted to change, plan strategies to change it, and then actually achieve a measurable change at population level. So what did our experience with implementing quality improvement in a high mortality, low resource setting lead us to learn? Well, it's very complex, took time to implement, but did show potential in strengthening the quality of care and improving demand for quality health services. One of the key learnings for us was that we had much stronger evidence in Tanzania than we did in Uganda, even though the same intervention had been implemented in both places. And we had a strong program of work to look at contextual data, And we feel that one of the things that was a difference between the two settings was that in Tanzania, district health managers have their own unmarked funds that they can use to support facility workers in the change ideas that they developed, whereas in Uganda there was no funding available from the district level to support the quality improvement initiatives. So that's it. Implementation was positive, was challenging, and let's all remember that change takes time. Thank you.